I will try to be very provocative today. You know that when we talk about atelectasis and PEEP, everyone becomes very much excited. And most of the work is the result of a great team all over the world of the provenance investigators, from experimental to clinical work. And those of you who are interested in our activities, this is our website where all our protocols are presented in advance. So, first of all, ventilatory strategies to minimize ventilating lung injury. We have three main ventilatory strategies. The first one is with high tidal volume, high driving pressure, low PEEP, or with low or high plateau pressure. This is red. This is what we know we should not do in any patient, at least during controlled mechanical ventilation, because we have opening and closing of the atelectatic area as overinflation attending inspiration. So don't do that. High tidal volume higher than 10 or higher than 6, 7 in RDS with relatively low level of PEEP, 5 or less should not be performed in most of patients. Then we have two other strategies. One is to keep PEEP relatively high, or in order to minimize atelectasis, and then the lung ventilated with protective tidal volume. And this is the so-called open lung approach. So open up the lung and keep the lung open. What I would like to discuss today with you is there is another strategy to minimize PEEP, so maintain some atelectasis, to maintain a sort of minimal oxygenation, and to gently ventilate the lung. And this is the so-called permissive atelectasis, and we call that close the lung and keep them rested. So try to look in a new way, no, and not to look at the past. So low tidal volume, we discussed the concept of energy today, and again, we have seen that low tidal volume is associated with less energy and less impact on the lung, and this is also associated with reduced plateau pressure, reduced driving pressure, and this is what we have discussed today. And we know from, if we mix together the studies on tidal volume, that high tidal volume is associated with higher mortality and better oxygenation, while low tidal volume is associated with low mortality and less oxygenation. So first concept, don't trust too much in oxygenation. We like to follow saturation and oxygenation, but this is clear demonstration that oxygenation is not the target. The best oxygenation is not the target. So atelectasis do not promote lung injury. This is a study from Toronto, from the Slatsky group, published in 2004. And they look at different models here. And you see here that the group with control with PEEP, so relatively low tidal volume and moderate PEEP level, or ZIP with 7 milliliters per kilogram. But what they found is when they kept atelectasis, but without not major ventilation, atelectasis per se were not associated here. There is the amount of inflammation in some in TNF alpha in this case was not different. So the concept here is that atelectasis per se are not damaging the lung if you don't touch the atelectasis. Higher PEEP is supposed to decrease the atelectasis, yes, and also to reduce lung injury. This is the very famous study in '74 from Webb and Ternay, which I think was never read or misinterpreted. You have one group with low pressure and low PEEP, no injury. One group with high pressure and low PEEP, a lot of injury, and many studies follow it with the same experimental design. But here, remember, high tidal volume and lower PEEP. And this group was with the same pressure, but with PEEP. And the consequence was that PEEP was preventing injury. But really here you have lower tidal volume and high PEEP. So you don't know if it is PEEP or tidal volume. But we love PEEP, we love to reduce atelectasis, we love better CT scan, we love better IT. And so we like the defect is PEEP and not low tidal volume. But really, all these studies mix it together, high tidal volume, low PEEP versus low tidal volume and high PEEP. So it's really tidal volume or PEEP. Very few experimental studies compare injury at low tidal volume and different PEEP. This is from our group, Patricia Rocco, and we look only at the low tidal volume here. The design is more complex, but low tidal volume. Increasing PEEP in an injury lung model. When you increase PEEP, you have less atelectasis, but you have increase in hyperinflation. So the question is better to ventilate with low tidal volume, with atelectasis, so you have some atelectrauma, or is better to volutrauma, or is better to ventilate with less atelectasis, so more atelectasis but not hyperinflation. This is the issue. Is better to have more atelectasis and less hyperinflation, or is better to have more atelectasis, less atelectasis and more hyperinflation? This is the issue. If the theory is correct, we should expect that the better effect should be here, so that hyperinflation determines less injury than atelectrauma. That's right. What we found was exactly the opposite. You see, this is, for example, interleukin-6 in the lung and many other mediators, were higher when we ventilated with less atelectasis and more hyperinflation, as compared to more collapse and less hyperinflation. This is also amphiregulin, which is an indicator of the stress of the cells. So this was reproduced in big animals, where we ventilated animals with lung injury at high tidal hyperinflection point with very low tidal volume and very low driving pressure, because we removed the CO2 through the extracorporeal circuit. And the other group ventilated at very low tidal volume with very low driving pressure, but at the lower inflection point. Again, we expect less injury here as compared to injury here. But we found exactly the opposite. You see here the lung with the high pressure, static pressure, because the animal were under extracorporeal support, low tidal volume, low driving pressure, no much atelectasis. Here, a lot of atelectasis, you see here, and less aeration, but we don't discuss perfusion, which is the same, but the yellow area at the PET are the area with inflammation. And you see much more inflammation when the lung was maintained at static pressure at end expiration as compared to the lung collapsed. So the concept is the static strain due to the PEEP is more injurious than dynamic strain. So atelectrauma, in our view, is much less dangerous than volutrauma, are not the same. And these data are reproduced also by Salvatore Grasso. These are different lung injury models. Lung recruitment, you see in purple, are hyperinflation. Look at the during recruitment, how much hyperinflation. And then the open lung strategy at end expiration and inspiration was associated with a lot of hyperinflation at end expiration and then inspiration. So remember, higher PEEP you use, higher hyperinflation, higher damage to the lung. The static pressure at end expiration induced lung damage. This was discussed before, you see, when you have even the reduction in driving pressure with higher PEEP, you can increase the amount of energy that you give, as I discussed in the previous lecture. So, I think we have to take care of recruitment maneuver and high PEEP in our patients. Higher PEEP impairs the lymphatic drainage. This is a review that we wrote last year. This is showing that in normal condition with lower PEEP, we have a continuous flow from the capillaries to the interstitium, where the pressure is negative in the interstitium, and this fluid is reabsorbed by the negative pressure in the lymphatic capillaries. If you increase the pressure in the alveoli, you increase the pressure in the interstitium. So you have less drainage here, and then you have less difference between the interstitium to the capillaries. So less fluid are reabsorbed by the lymphatic drainage. So PEEP impairs the lymphatic drainage. PEEP impairs the right ventricle. This is when you have low level PEEP, relatively low, or minimization of PEEP. You have alveoli open, alveoli collapsed, and some perfusion here. If you increase the PEEP, you recruit the lung, but you squeeze the alveolar capillaries. And so you increase the pulmonary artery. And in fact, at the increase of PEEP, you have an increase and impact of the right ventricle on the left ventricle. And if you want to decrease the pulmonary artery pressure, when you are giving PEEP, you have to give fluids. So when you recruit the lung with PEEP, you de-recruit the capillaries. So if you want to recruit the capillaries, you have to give fluids. So if you give the PEEP, you have to recruit the capillaries with fluids. If you recruit the lungs, you de-recruit the capillaries, and that high PEEP fluid yield capillary recruitment and may improve the right ventricle, but you have to give more fluids, and you reduce the lymphatic drainage. So you increase further the lung water in the lung, especially when you will remove the PEEP. What about patients? Again, back to the patients in anesthesia. 2 big studies from our team, now more than almost 3,000 patients. High PEEP means 12 of PEEP, which was the PEEP on the CT scan to have a better aeration and recruitment maneuver, versus PEEP 5 or less. In non-obese and obese patients, no difference in the complication. But as I mentioned before, there were some a little bit more, but not too much in terms of rescue. The saturation just corrected with FiO2, but major hemodynamic effects. PEEP impairs hemodynamics. And as I show you, this is a major impact. So higher PEEP, even during surgery, is not good. When we look at the patient with RDS, this is an example with a lot of atelectasis here. Driving pressure is higher if we ventilate with a certain tidal volume. Then we can apply PEEP and we reduce the driving pressure. And if we apply too much PEEP, driving pressure increases, okay? So the idea is that if we set PEEP according to the best driving pressure, we get the best results. Again, this study, which was discussed today, can be criticized, but anyway, there was a major reduction in the driving pressure from at least 13.5 to 11, not so much. I remember in our last study, in Probese trial, we reduced the driving pressure of 5 centimeters of water, 5. So what you want more? We reduced the driving pressure, but the complication was higher with PEEP. And even they, in a different setting, they found that they reduced the driving pressure. PEEP was individualized. Then now there are the new data from Amato, blah, blah. Okay, this is the study. There was even higher mortality. Why? Probably because they impaired the right ventricle with higher PEEP, higher than 15. And when they look at the sub-analysis, post-hoc analysis, you see that the group of patients with pneumonia and vasopressors, they had the worst effect of higher PEEP and recruitment. So again, I think that PEEP is considered only to improve the lung, but PEEP has major negative effects on hemodynamics. And even they found higher mortality with recruitment and higher PEEP when driving pressure was lower than 15. Why? Because these patients were likely less severe, and less severe you are, worse are the effects of higher PEEP. If you put together all the study, the only positive effects are when you mix the effects, the Amato and Villar, low tidal volume with high PEEP versus high tidal volume and high PEEP, okay? And then you have some positive effects. But this effect is not due to the PEEP. This effect is due to the tidal volume. When you have all the other studies with recruitment maneuver, without recruitment maneuver, whatever you want, there is absolutely no difference in terms of outcome and even more complication with higher PEEP. So keep it simple. The best PEEP is the lowest just enough for the lung and for the heart. So we developed this concept that if if you maximize the PEEP according to the driving pressure and the maximal oxygenation, which is the theory of open lung approach, you reduce the atelectasis, but you have a major impairment in hemodynamics, and you increase the area of overdistension. Remember, my concept today is PEEP induce injury because of the static pressure in the lung. While if you maintain some minimum atelectasis to minimize oxygenation, and you don't touch the atelectasis, minimizing the tidal volume and plateau pressure, you get better effects. Of course, if you use high tidal volume here, you touch the atelectasis, and this is dangerous to the lung. So just gently ventilate the aerated lung, keeping atelectasis at rest, and use the minimal PEEP in order to minimize the right ventricular impairment and oxygenation. So the final concept here are don't run towards the highest oxygenation. I like to see 100% oxygen, who cares of 100% oxygen? But please rest and sweet dreams. Tidal volume and plateau pressure are very important. Driving pressure, respiratory rate, we don't know. For sure, high PEEP, looking at the best oxygenation is not good, and perhaps even more recruitment maneuver. Remember, the prone position should be associated with this strategy. If you look at the minimization of PEEP on minimizing oxygenation, because this is the best way. This is data from gas tissue ratio in normal subject and RDS. You have a more homogeneous distribution of pressures in prone. And so the prone position is the best method to open up and keep the lung open at the minimal PEEP. This is the recruitment maneuver that I like, because you open the lung without changing the pressure. You just change the regional pressure. You homogenize the regional pressure, but you don't change the pressure in the alveoli. That's the difference. So conclusion, again, back. These are the patients that we don't need to use excessive level of PEEP and eventually to use non-invasive ventilation. Again, I remind you, my alarms are on tidal volume and respiratory rate. Back to the RDS patient, when patient the PO2 less than 150, you see the positioning here, prone position, because we have to ventilate, in my opinion, with low tidal volume, and to adapt this tidal volume again on driving pressure. If at 6 we have driving pressure higher than 15, we should reduce further tidal volume up to 4 milliliters per kilogram. That's why I like driving pressure, to titrate tidal volume, not to titrate PEEP. We have to minimize the respiratory rate. It can be 20, 25, 30. You see, I don't use the terms high or low. I use the term minimize. This, I think, something that is very important. To minimize the plateau pressure at 25, 27 and driving pressure according to the tidal volume. How to set PEEP? I think we should set PEEP according to the minimal saturation, 88, 92. Why to follow 97, 98, 99, 100? Why? We just increase the possible damaging of the pressure. And this means that even we can have 15 or even 17 in some patients if we need. So we are not talking about high or low. It's the minimal PEEP to achieve the minimal saturation. We don't use anymore, very, very rarely, the recruitment pressures because they further can injure the lung. Prone position, as I show you, has to be matched with this because I show you that prone position is the best method to recruit the lung. I like this recruitment, but not with PEEP. So minimal PEEP with prone position. But we learned that prone position is used in 13% of RDS, and even in patients with ECMO centers, they use in less than 20, 30%, which is an shame to me. We try to minimize as much as possible neuromuscular blockade agents. I like very much the last study from United States that was presented this morning. And I think here we have to learn more if we should use assisted ventilation, even Probably this number should become 100 in the next future. So patient up to 100, first attempt should be assisted ventilation. And eventually, when below 100, to do this. But at the moment, I think we have evidence for 150. But remember, the BURST trial is coming up from the French. Not many patients, again, within for my, but showing that assisted is comparable with controlled mechanical ventilation in patients up to 100 and less sedation. And ECMO criteria, of course, for just the minority of severe patients. So that's our point of view. And change your mind, close the lungs and keep them rested to minimize VILI in RDS and be less aggressive with your patient, even with the use of IPEEP and recruitment. Thank you so much.
I think, though, I'm probably the wrong guy to be talking about this because I don't use PEEP and I don't use recruitment maneuvers. But short of that, what I want to do is just maybe try to think about things a slightly different approach. And for those of you who don't know, this is actually a review article. I think it's actually very well balanced by Professor Pelosi. It's actually very good. Now, most of it, I would say a lot of it I agree with, but there's a few things that I would not agree with, certainly for the sake of a pro-con debate. So this is my position, actually. I think we should not let the lung ever collapse. We should keep normal lung volume. You know, the lung's biology is actually dependent on a lot of gas. Surfactant, type 2 cells don't work without oxygen, without air. You know, that happens to you your very first recruitment maneuver when you were born and actually took your first big breath. That's an important idea, is keep the lung healthy. You know, I'll just tell you a quick story. Medical students in our lab, they were looking for a summer project last year. So I asked them to look at energy of breathing during extreme exercise. They presented this at SCCM as an abstract. So the work of breathing in joules is 19 times higher in strenuous exercise than any of the ventilator injury data. If you correct for tidal volume, it's about 150 joules. So obviously when you're exercising, your tidal volumes are 4 liters, transpulmonary pressure of 38. These are studies that were done with exercise physiology. So what I want to say is that we look at the ventilator as the truth. And that's not what we're treating. The real critical physiology is unfolding in the lung. It's the lung that we're damaging, not the ventilator. So we need to protect the lung. So I think if we don't understand what's going on there, how can we talk about strategies? How do we know what's the right strategy? And I would argue that there's a lot of things we simply don't know. We've made some assumptions. So for the moment, we'll go to an alternative universe. Everything will be fine in a short period of time, so don't worry about it. But I think if we just relieve ourselves from ventilator strategies for one moment and just try to understand what we know and what we don't know about this. So let's just start with the baby lung concept. The baby lung concept's more than 30 years old now. It's a great concept, great idea. But as all ideas, we need to consider whether things need refinement. You know, for example, the studies done here, the first study was actually done in '87, published in several patients, and rightfully so. We were looking at x-rays and trying to take a 3-dimensional object, I would actually argue a 4-dimensional object, because it's not static. So when we look at CAT scans, we have some limitations. These are static images. They actually can't give us the subvoxel data we need at the alveolar level. So in other words, we don't know what's recruitment by CAT scan, technically. You don't know that. For all you know, you're blowing up the duct. Nothing to do with alveoli. It doesn't have the resolution we need to make these determinations. So it's important to consider that. And then, of course, we have this sort of anatomy that's always been broken down: non-dependent, healthy lung, protect the normal lung from overdistension, right? That's the baby lung idea. And I actually agree completely with Dr. Pelosi. Do not mess with the collapsed lung. You either recruit that lung or keep it stable. As soon as you start penetrating, and remember that the studies have never really separated dynamic from static well. There's no way you can go to 12 mLs versus 6 mLs without perhaps penetrating. Maybe there was no overdistension. Let's just say for a minute, 12 mLs did not actually produce overdistension. What it did was penetrated into the atelectatic lung and created unstable inflation-deflation cycles. Maybe that's a possibility. At least we should entertain that. Because short of actually looking directly at the alveoli, we have assumed, because the ventilator in an animal lab says 30 mLs per kg or 70 mLs per kg, that we're overdistending the lung. I'm not sure what happened here. Hold on a second. Yeah. Okay, sorry. I didn't really want to talk about that, but I will anyway. We can blame the Italians. Let's blame the Italians for this, because the Latin translation for acinus is grape, like seed. And so all the textbooks started drawing these grapes on a stick. And the balloon on a stick thing perpetuated. We talk about Laplace's law. Well, this has nothing to do with the lung. The lung doesn't look like this. The lung looks completely differently. The lung is actually a shared wall structure, and it's actually very resistant to overdistension. Because when you apply pressure, it essentially equalizes. Now, in our lab, this was done many years ago. When you guys take a big giant breath, you don't actually increase your alveolar size. You increase the number of alveoli. Actually, this has been reproduced. This is looking at in vivo microscopy. So we always go ask the alveolus. When in question, ask the alveolus. Or recently, hyperpolarized MRI, which can give you subacinar views, it also confirms that the major mechanism of lung inflation, normal lungs, is recruitment. So anisotropic volumetric growth of the alveolar space doesn't occur. As the lung inflates, the neighbors sort of keep everyone in line because of the architecture of the lung. It is not individual sacs of balloons. It has nothing to do with a balloon on a stick. That's important, because if we get the anatomy and physiology wrong, then a lot of our premises are really quite inaccurate. Here's the MRI I was talking about. Sorry, I'm going to go through this very quickly because there's a lot to cover, actually, to put forth an idea that challenges our sort of assumptions. But that's really what I want to try to do. So this is a study from our lab again. And so here's control, normal lung, 6, 12, 15. Look at the alveoli circle, no change in size. The lung doesn't, in fact, it takes, to actually injure a human lung, a healthy human lung, you need 30 to 70 mLs per kg. So what is it about the normal lung that is so resilient to injury? I think it's a reasonable question. So of course we've been doing a lot of this because, again, I would come back to define the problem. The solution is likely to be easier. I don't really know what the right solution is, but I can tell you that when you look at the normal lung, this is what it looks like. It barely moves between inspiration and expiration. It's just a sea of alveoli. Now, we have in this article we wrote for the Journal of Applied Physiology, we've taken these things and we've tried to make them, and these are all downloadable, by the way. And so the homogeneity of the lung is very important. So instead of recruiting the lung and trying to blast it open with pressure, using PEEP, all these things, why not just keep the lung healthy and keep it stable? And I want to come back to that. I want to make that distinction between that. Now, this is the problem. This is the problem. And this is why I would say, if you let the lung collapse, leave it collapsed. And make sure you do not penetrate into that, which you can with your tidal volume or half-hearted PEEP or whatever technique you want to use. And I do agree with that. But here's the problem. Whenever you interrupt this uniformity, you create an unstable part of the lung. Remember that there are many reasons why the geometry of the lung is inherently unstable. That's why we need stabilizers. Surfactant. It's a compromise because you can't put 70 square meters in this little box here unless you did something. We would look very bizarre if we wouldn't fit in the room, I guess. But see, now watch. Well, this is taken from microscopy. Now watch, during expiration is where you overdistend. So instead of the baby lung being this top of the lung, non-dependent is the normal lung and the overdistended lung, what's really happening is there's little islands of clusters of alveolar instability or unstable inflation-deflation cycles. And right there you have both cyclic collapse, which allows the lung to actually overdistend. Now I'll show you the actual pictures. Let's just go and take a look. This is obviously colorized to make it easier. So this is from our lab. Now watch what happens when this guy collapses. Watch what happens to, remember they're sharing walls. If one collapses, you have to distort the neighbors. And this is exactly what happens. And this is what people talk about. Instead of shear forces, we're talking about stress multipliers, stress concentrate, whatever term you want. And this is important as a concept. Now, it's not enough to show you this. Let's see what else is telling us that this unstable inflation. Again, I'm not going to say recruitment. I'm going to say unstable inflation. And again, I would point that what we really need to do is consider whether somehow what you do on the ventilator, for example, so you come up to the ventilator, you turn down the tidal volume. Is that what you get in the lung? Or could there be 3 other consequences of you turning down that tidal volume? Because obviously there may be more than what you just bargained for. So one of the things that in some of the later studies, and again, this is looking at a better way to examine the anatomy of the lung and actually to make it more temporal. In other words, we need to remember this thing's moving, right? It is not the image of a CAT scan. There's a temporal relation. It's not just spatial. We need to understand the temporal relationship. We also need to understand how these things evolve. So when you see a CAT scan that's typical of the baby lung ARDS, how did it get there? How did it evolve to that point? Those are important things to consider. And again, the real reason here is not to sort of challenge the mainstream concepts, but it's really to refine our thinking. I think this is important in anything we do, is to refine. So here, overdistension occurs during atelectasis, and it's developed when you look at these MRI techniques. In fact, if you look at this, the recruitment makes alveoli smaller. So here we have alveolar recruitment associated with smaller air spaces. Now remember, this is hyperpolarized MRI. So basically, you can get down to the small airways. You're looking at the signal at the small airways. So this is much more sensitive than a CAT scan, which is really limited to the ducts. In fact, here's just a quick thing. Watch when this lung expands here. Because it's connected, the other one gets smaller. I don't know if you saw that. Did you guys see that? Was that too fast? Let's play it again quickly. Now watch what happens here. You see how it gets smaller? Those are connected. So the question is, do you do that? Now, what happens if we use low tidal volume strategy, we induce a mild injury, and we look at the distribution of the injury over time? So now we're just going to try to understand this a little bit more. So this is a model where, again, now what we're going to use is paired CAT scans. This is actually a technique to improve the resolution, the temporal resolution. What I mean by that is end inspiration, end expiration, and you're looking for the change in a particular region of the lung. So you're identifying that region. And what you're trying to do is understand whether it's gaining air, losing air, and whether it's doing that cyclically. So this is the result of the study. Now this is a 24-hour study. That's important because many studies, some of which I'll show you, are 2 hours, 6 hours. That may not be enough for us to really understand what's happening. But let's just take a look here. So use of the current principles, protective, do not protect worsening lung strain, and there's a distribution in the first 24 hours of mechanical ventilation when you're supine. Lung injury progresses, tidal strain are increasingly distributed to regions that are relatively high aeration. In other words, could the atelectasis be driving the overdistension in the non-dependent part of the lung? At least this is what this study says. And these things are associated with the potential to create more inflammation and expression of stretch. They measured a bunch of things in this. And what they're asking for here, is recommending, is making the lung like a normal lung. It's homogeneous and it's stable inflation. It's not unstable inflation and it's not heterogeneous. We all know that that's one of the problems we fight with. Just think about the fact that when you send a ventilator breath down this heterogeneous lung, we expect to control that column of gas? can we really control that column of gas? Or is the lung dictating what happens with that column of gas? So here's prone positioning. Now remember, prone positioning has nothing to do with oxygenation. In fact, when you look at the benefit of prone positioning, it had nothing to do with the PO2 ratio, PF ratio. The people that survived didn't have a higher PF ratio. Now we use it when people are extreme for hypoxemia, but what if it's a way to recruit the lung and do away with these unstable areas of inflation, deflation? So if you look at the CAT scan here, this is after injury. The top is supine and the bottom is prone. I think you can see the heart's flipped over. You can see the bases look better. And here there's a 48% change from normal lung to poorly or no aeration versus a 27% change after injury in the prone positioning. So you can see that. And if you look here, end expiratory alveolar heterogeneity. Remember, this is where you get recruitment on inspiration and then it disappears on expiration when you pair the CAT scan images. So again, it's remarking to this. If you look at the bottom there, the gray, is there a printer? Pointer? Oh, here it is. Okay, sorry. So if you look here, this is the prone patient, prone animals. These are sheep, by the way. So these are sheep, and you can see the heterogeneity is increasing when you do this. Now this is low tidal volume strategy with low PEEP. We're not using recruitment maneuvers, we're not doing anything other than conventional. And so the idea is that it's going to drive ventilation here. In other words, where's that distribution going? Where's that protective tidal volume going? Do we know? We don't really know the distribution. That would be like saying we know the cardiac output's distribution during septic shock. It can be high, but we don't know if it's distributed everywhere. So if you force this, even 6 mLs, 4 mLs could be too much if you shift it to that area of the lung. That's just actually from our lab. Now, there's a body of literature, and I'm just going to cite one because I work with Jason Bates. And he's, in this paper, he's trying to quantify this. And it seems to be that what you need first, in other words, what is the main role? We talk about atelic trauma, we talk about all these things, but how do they work together? Which one's more important? You know, we heard about volu trauma, barotrauma, but it seems as though you need that prerequisite. Again, come back to the normal lung, it can handle a lot of volume. Even when you think about the bigger tidal volumes, when the lung is healthier, it can withstand a much bigger tidal volume. It's really when the lung gets diseased and it has heterogeneity that becomes a problem. So it seems as though maybe everybody's correct, but you need a proper sequence. So you need to create the unstable inflation. That's going to create these little islands throughout the lung, not distributed just sort of radiographically by CAT scan, dependent, non-dependent, but entire areas. And certainly older papers have looked at this, where the atelectatic area is driving the overdistension. Now let's take this a step further. Now we're going to look at this paper. This paper is actually trying to look at where you have stress concentrators. And this is actually using Berlin criteria, but the first patient is normal. And these areas here highlight, these false color images highlight the areas of increased stress. And of course they highlight because the tissue is different. So it's around the pleura. In the normal lung, there's nothing in the parenchyma because mechanically the tissue is the same. It's really when you have different tissue that responds differently to force or energy that you have this. So here, as you go from mild, moderate to severe ARDS, you see the stress concentrators and the inhomogeneity is really throughout the whole lung. It's just progressing into this. And certainly we know that patients can progress. It doesn't mean that you're mild, you're going to stay mild. And so it can certainly progress. So if we come back to the hyperpolarized MRI, and again, the advantage here is that you can see things that, there's another paired CAT scan. So this is normal. And again, what I mean by paired CAT scan, here's a voxel, and we're looking at a very small area. And in normal end inspiration, there's really no change. When you go here from end inspiration to end expiration, you get this parametric response map that shows areas where you're changing the Hounsfield units. And that's suggesting that there's a transition between end inspiration and end expiration. So again, we're talking about unstable inflation. So here, you can see this is actually a group of patients. So these are 9 patients. So they did a lot of studies on rats and pigs, which I'll show you. But these are survivors and non-survivors. And just to give you a sense, the red here is severely injured lung. It's actually not changing. It's not normal tissue because it's not full of air, but it's not actually changing during the paired CAT scans. The yellow areas and the orange areas are what they call areas at risk. In other words, they're going through unstable inflation-deflation cycles. And of course, the green is healthy lung. So these are the patients that survived. They found that it doesn't matter how much lung injury you have. In fact, you can have a tremendous amount of injured lung, more than any of these non-survivors actually, but it really depends on how much you have in terms of this map where you have unstable inflation-deflation cycles. Yeah, okay. Not enough time, yeah. So here's that was a better predictor than everything else in terms of doing that. And again, I won't go through all of this because of the time, but basically prone positioning changes unstable inflation deflation cycles and actually seems to prevent this. Now, let's talk about some other aspects of collapsing the lung. We talk about the short-term thing, there's no inflammation and so on, but for years, people have written about this. First recorded documentation is in the 1927 of what happens when you have pulmonary fibrosis, when you collapse the lung. And there's a relationship between collapsing the lung and you get a cicatricial type of fibrosis. Generically, it's called collapse in duration. And actually, it's one of the main mechanisms of pulmonary fibrosis. In fact, when you do paired CAT scans on people with pulmonary fibrosis, there's healthy lung hidden behind the fibrotic lung, even in people who have had long-standing pulmonary fibrosis. So one of the major mechanisms seems to be collapse. So because we have collapsed areas next to healthy areas. Now, this is a paper that is in press, but I think it's an important thing because we don't know the consequence of leaving the lung down. Just because you say we are resting the lung or whispering it into the ventilator, it doesn't mean you're resting the lung. We don't really know what you're doing to the lung. At least I don't think we do. And so could we do that? One of the key things here is surfactant. Everything seems to come through there. Surfactant, cyclic collapse, shear forces, stress concentrators, and this is the pathway to fibrosis. And so can this happen as actually lung injury? Now, I can tell you in the United States, we're doing a lot more ECMO, and we're having a lot of people that, because the technology's improved, that are still alive, but their lungs aren't working. And so we end up going down the path of, are we making these guys pulmonary cripples? The only out is pulmonary transplant. And the likelihood of that being successful is much lower if you're on ECMO. Now that's important because you get to lose 2 patients, not just 1. You lose 2 because somebody else could have had that lung that might have actually had a good function. So I would just be careful that we're not actually creating more problems. Now, very quickly, to me, this is the ART trial. Does PEEP really work? Well, first of all, how do we figure out the right PEEP? We use FiO2, PO2. There's no relationship. Lung mechanics don't tell you about regional spaces of heterogeneity. Transpulmonary pressure, I think that was well illustrated today. Make up a number, I guess. We could certainly do that. Opening pressure in the lung, the 15 and 30 may not even open the lung. Who knows what pressure you need? And certainly if you get into the situation where you're forced to rescue a patient, you will probably need more pressure or you need to do something more invasive. Of course, I'd rather avoid all that. Now, I want to also make a quick distinction between recruitment, which in my mind has nothing to do with stability. Just because you use a recruitment maneuver for 40 seconds, does that make the lung stable? If you break your arm and your fracture is reduced anatomically, I'm not going to cut your cast off. There's a period of time where your lung gets stable. We don't make the distinction between stability and recruitment. And the PO2 signal is actually very lousy. And we actually did a study that showed that despite your PO2 going up in a linear fashion with PEEP, alveolar stability is just not there. The lung is still opening. Totally silent, of course. There's nothing on the ventilator that tells you you've got unstable inflation-deflation cycles. You don't know that you're deforming the lung to the point where it's taking a load in a particular area. And I would just say PEEP doesn't work. At least I don't think it works the way you think it works. I don't know of any study that shows PEEP stabilizes the lung. We assume it does. This is kind of relevant because you were looking for a plug this morning. But is that the best way? And so the question is, look what happens to PEEP. This is in vivo. This is a surfactant depleted lung. And watch what happens when we use our beloved 5 PEEP here. Anytime now. I think it's coming. There's 5 PEEP. Now watch, a little more stable. A little more stable. Oh, it's gone. PEEP actually has a hard time stabilizing the lung. It may not actually be the right tool. Remember, PEEP's more than 50 years old. We still don't know what to do with PEEP. I don't know, is it the only thing? Now, I just want to show you a study we're doing right now. We're just about done with this. But we're going to use time to control the behavior of the lung instead of pressure. So here what we do is release the pressure. And over here you have, where's my pointer? Just very quickly, here's your pressure here is in the dotted lines here. So this is the pressure. So we release the pressure, and then we go back up when there's a certain amount of time for expiration. So we limit that expiratory phase to a very brief period. And you can see alveolar volume over here. So the alveoli are actually shrinking, and then they go back up. And then we measured the pressure here, because obviously if you stop the breath, there's going to be some retained pressure. So we derive this retained pressure, and then we set it on the ventilator. So this is why it's roughly 15 a PEEP, 14.9 a PEEP, and that's what we're holding here, is that much level. But here's the alveolar volume. It's still sliding. It's still creeping down. There's a redistribution of gas. There's really nothing static when you hold your breath. The lung is shrinking when you hold your breath. You absorb gases, the redistribution of the gas. This is what it looks like. This is one alveolus. Now this is not setting any PEEP except controlling time. We get in pressure, retained pressure, and that's the pressure we decided to use here. Basically to isolate time as a variable. So that thing completely collapses even though you've set the exact same pressure. So maybe because the lung is a time responsive organ, it's really a viscoelastic organ, it's not elastic. And so that might be important. Let me just show you very quickly a study where we decided to look at what PEEP does. And just very quickly, this is control. We're looking at the distribution of air in the ducts, and purple is the alveolus, and red is the tissue. So then we injure the lung, and I'll just go to PEEP for now. When you go from 5 to 16 of PEEP, you actually don't increase the alveolar gas volume. You just blow up the ducts.
Can I ask you for a concluding slide?
Yes, okay. Yes. We started late, you know. Okay, so so basically, you know, PEEP drops the resistance. And so we use it in diseases like COPD, which have a very low elastance. And if you drop the resistance, that's good. We want to empty the lung. But what happens if it's a disease with high elastance and we drop the resistance? Could we actually empty the lung? And actually, look, with ZEEP, you get better movement. You don't empty the lung as fast as if you set PEEP. Now, I will end, I promise. I'll just find the last thing here. Just on lung water. I agree, that's a lymphatic that's completely collapsed with PEEP, low tidal volume strategy. That's time control where you're trying to stabilize the lung. Lymphatics are huge and dilated. All the edema is around the airway, which it should be because that's where the lymphatics are. It's not in the tissue like it is here. So I think there's potentially other ways of keeping the lung stable and actually not letting the lung get to that point where you have to re-recruit it. I'm actually against that. I think that's kind of a failure. And of course, keep your patient breathing and minimize the time on the ventilator because the ventilator is really not your friend nor your patient's friend. So I think I'll conclude there.
Questions? It is 5 o'clock. questions for our speakers? Are you convinced? Who's convinced? What a few converts here.
Well, hopefully it's not a convince thing. Hopefully it's just a think about things thing. Yeah. I mean, I certainly would hope that it just gives people a little more time.
If you want, we can have a little bit,
Sure.
just a few comments on that. So, first of all, I fully agree. I had no time to discuss that. Was exactly what we found also in our study that I showed you in anesthesiology, that it's better to try to fully open the lung than to be in the middle. So we found even more injury. I had no time to discuss the details, but we found that moderate PEEP, so it increased even because you touch the atelectasis, but you don't open all of them, and so we found even more injuries. So, or you are more in one side or in the other, but in the middle it seems to be the worst. The second point is that it was mentioned that PEEP may homogenize the lung. This is true, but you pay something in terms of overdistension. So the question is, if it's homogenization, how much you have to pay in terms of overdistension. Our data suggests that when you homogenize without prone position, that I agree, you showed also, is more homogeneous, but you don't touch the pressures there, just the regional one, which is another issue. That overinflation was more injurious, and even you mentioned the fibrogenic. I agree. What we found that hyperinflation was more associated with fibrogenetic activation. So my feeling is that if you overinflate the lung, even statically, you even promote more overinflation. And then I conclude that we have seen a lot of images, but remember the hemodynamics. My point today is that if you apply higher PEEP level, looking for the higher oxygenation or lower driving pressure, whatever you want, remember that the other side is hemodynamics. That, in my opinion, I show you the data in patients during anesthesia, and also probably the negative results, or really negative in terms of higher mortality in their trial, in my opinion, were very much linked with hemodynamics. So my feeling is that when we increase too much pressures, and my feeling is higher than 15, we have to think, because the impact on hemodynamics and pulmonary pressure may be very important. So one side is the lung, but the other side is the hemodynamics. And my conclusion today, from my point of view, is that we were very, we got a lot of attention to the lung in terms of mechanics, in terms of imaging. Everything is nice, but we have not to forget the hemodynamic side that, in my opinion, was forgotten in the surgery. I just can tell you, give number, even in Probese, have you seen? Overall, well, independent of the level of PEEP, there were 60% patients, and also in Provilo, with hemodynamic problem, and 20% with respiratory problem.
Can I have a quick rebuttal?
And so hemodynamics, I think, is very important.
That's really important, but I would just add that the lowest load on the right ventricle is at functional residual capacity. So the extremes of lung volume are really where the right heart is unhappy. So if you do have a lot of collapse, you will load the right ventricle. There's actually studies that show that, echo studies showing that. So it's, again, not just a straight linear idea. And that's why I think that what you want to do is optimize lung volume by not letting their lungs collapse. And if you have collapse in the OR, which definitely happens, it's just part of going to the OR, not breathing, monotonal ventilation, all those things. But that collapse, the surfactant is still there. So you have 12 hours basically, because once the lung collapses, you don't make new surfactant. I'm talking about surfactant protein B, which is what lowers surface tension. You have 12 hours. You're not going to stimulate the lung to type 2 cells to make more surfactant unless you fill it with air and stretch it. Just the right amount of stretch. Not too much stretch, that's what stimulates surfactant. And that makes it so much easier. Some people in the anesthesia literature call that loose atelectasis, just very easy to reinflate. But if you just let the lung stay down, especially denuded epithelium of the lung. This is one of what's described in what causes the fibrosis is the walls stick, the denuded base membranes stick, and you just close the alveolus. It becomes a solid organ, and that's pulmonary fibrosis. So I think that's an important.
Can I have a question for
Yeah.
you? How do you set PEEP in your patients?
I set 0, but I control the time. I didn't have time to show you that I think there's a difference, and this is why I don't like PEEP. I think there's a difference in using time as the manipulator of it. And remember one thing about energy, I think this is important, is that you don't pay any money for time as long as it doesn't change the rate. So because the lung takes forever to sort of stabilize, instead of blasting the lung open, you can unwrinkle the lung, because that's what it does, by just holding the time. And then because the recoil forces are so high in these patients, you have to stop the time from coming out. And this is what I believe is a better way to homogenize the stable lung without PEEP.
No, yes.
Set PEEP.
I understand, but which is the target? If I will not mention any more PEEP, but which is the target, and you set mechanical ventilation, especially in expiration.
Yeah, so
it's oxygenation, it's driving pressure,
No.
it's plateau pressure, it's hemodynamics, it's the combination.
all those things, and we certainly don't we don't want to get into a rescue situation. At least that's my preference. Obviously sometimes we're forced to, but the same philosophy applies. And I would just say that and again, it's a little bit hard to talk about here, but because we're talking about increased elastance, anytime the lung collapses, you have increased elastance. That's what happens. The recoil forces increase. And so when you inflate the lung and then let it passively deflate, that is elastance, that slope of that line. And so as elastance increases, the slope changes, and your time has to get shorter to control the behavior of the lung. So basically what you get is an automatic retained pressure, and you get a much smaller tidal volume. The tidal volume is frequently, when we rescue patients with a time control method, is actually frequently much lower than the 6 mLs per kg, because the elastance is so high. And instead of the lung emptying like this, it's emptying like this, because the recoil force. And so since the 40s and 60s and 70s, classic physiologists have written about the elastance of the lung through passive deflation. So we have a real-time monitor, and so I don't know what PEEP to use, but the lung sort of tells me. I know that sounds crazy, and I don't know what tidal volume to use, because I think it has nothing to do with body weight. I think it has to do with compliance.
In fact, I think, as I said, that tidal volume should be set on driving pressure.
Well, certainly that's another way to do it. And yes, I agree.
I think we got the gloves
Yeah.
on.